Hi, my name is Victoria Friedman, and I am going to be presenting a case study that reviews the treatment of atrial fibrillation in the older adult. Rita is an 80-year-old female who comes to the office today for a discharge follow-up visit. She has been taking Warfarin and metoprolol for her atrial fibrillation. She was recently admitted to the hospital for a GI bleed. This was treated endoscopically and with intravenous proton pump inhibitors. She received 2 units of packed red blood cells for the drop in her H&H, and she also received 2 units of fresh frozen plasma along with vitamin K to reverse her INR that was supratherapeutic. Her labs normalized, she had no further bleeding, and was discharged home 4 days after her admission. Upon discharge, she was told to follow up with her primary care provider regarding resuming her home medication. She comes in today wondering if she should continue her warfarin or if she should switch to another medication. So Rita's past medical history includes hypertension that was diagnosed at age 50, an MI at age 60. Her atrial fibrillation was diagnosed at age 65. Her family history includes her father, who is deceased at 55 from heart failure, her mother, deceased at age 60 from breast cancer. Her daughter is 55, she's living and she has hypertension. Her son is 50, he's also living and has hyperlipidemia. Her current medications include metoprolol 25 milligrams twice a day and warfarin once a day dosed on her INR. It is worth noting that over the last 6 months or so, there has been some difficulty in getting a therapeutic INR, and Rita has required frequent INR draws to dose her warfarin. Rita has no known medication allergies. Her social history, recently Rita lost her husband of 65 years and expresses sadness about this, but relays a strong support system of friends and family. She smoked half a pack per day between the ages of 15 and 50, which gives her a 17.5 pack year history. She drinks 2 glasses of wine on Monday nights while watching The Bachelor, and 1 glass of wine at lunch after church with her friends on Sundays. She walks her dog around the neighborhood 3 times per week and eats a mostly vegetarian diet. She currently lives alone in a 2-story home and reports that she's fallen 3 to 5 times in the last year with no significant injuries. Overall, Rita denies any significant weight loss or gain. She denies fatigue or weakness. She denies rashes or lumps on her skin, and she denies dryness or changes in her hair or nails. Rita denies a headache, recent head trauma, dizziness, vision or hearing changes. She denies nasal drainage or bleeding from her gums. She denies shortness of breath, a cough, or coughing up blood, and she reports her home blood pressure readings have ranged from 120 to 150 systolic over 80 to 90 diastolic. She denies chest pain or pressure and does report the occasional palpitation that has no associated symptoms. She also had a transesophageal echocardiogram done when she was diagnosed with Afib 15 years ago. She denies heartburn, nausea, or changes in her appetite, and she does have the recent hospitalization for the GI bleed, but has had no changes in her bowels since her discharge. She denies leg cramps, varicose veins, or swelling in her calves, legs, or feet. She denies joint pain or stiffness, but does express that over the last year or so, going up and down the stairs to her bedroom has resulted in some weakness. She states that the falls that have occurred over the last year have occurred when going up and down the stairs. She denies easy bruising or bleeding and states that she has had no reactions to the blood products that she recently received during her hospital admission. On physical exam, Rita is an older adult who is relaxed, well-groomed. She's sitting comfortably on the exam table and appears in no acute distress. Her skin has good color throughout, and she has no rashes or lumps noted. Her nails are without cyanosis. There is bruising noted to her bilateral knees and right forearm that the patient states are from a recent fall. Her hair is of average texture. Her scalp is atraumatic without lesions. Her sclera are white, her pupils are round and reactive. Her tongue is midline, her dentures are in place and they fit well, and she has no lesions or bleeding noted to her oral cavity. Her breath sounds are vesicular throughout with no adventitious lung sounds, and her heart rate is irregularly irregular with no murmurs noted. Her abdomen is without scars, her bowel sounds are active throughout, and she has no tenderness or masses noted on palpation. She has no edema noted to her extremities, her calves are non-tender, and she does have palpable radial, dorsalis pedis, and posterior tibial pulses bilaterally. She has no joint deformities. She has full range of motion in her hands, wrists, shoulders, knees, and ankles, and decreased range of motion to her spine. Her strengths are intact throughout, however, there is decreased strength to her lower extremities and hands. Her lab values show a hemoglobin of 11. Normal range in females is 12 to 15.5 grams per deciliter. Her hematocrit is 33%. Normal range is 34.9 to 44.5% in females. Both of these are a bit low. Could be a result of her recent GI bleed and her H&H responding to her treatment. Her white blood cell count is 5.7. A normal range is 3.5 to 10.5 billion cells per liter. Her platelets are 300. A normal range is 150 to 450. So both her platelets and her white blood cell count are normal. Her creatinine is 1.3 and her BUN is 19. A normal creatinine is 0.5 to 1.5 milligrams per deciliter in females, and a BUN range is 7 to 20. Her creatinine is a bit high, but Rita is 80 years old, so her change in her kidney function could be attributed to her age. A BNP was drawn, which is a measure that can help with the diagnosis of heart failure. Values depend on age and gender, and they are higher in the elderly and women. Generally, a BNP of less than 100 means that heart failure is unlikely, and Rita's BNP was 50. Her TSH is 2.0, range that is normal is 0.4 to 4.0, and her INR is 3.5. The INR that is therapeutic depends on what the patient is being treated for. Rita is being treated for anticoagulation for Afib that is non-valvular. So the therapeutic INR for her is 2 to 3. A higher INR indicates a longer time to clot and an increased risk of bleeding. So Rita's INR is a bit high at 3.5. Her vital signs are 36.7 for her temperature. She's got 20 breaths per minute, 87 beats per minute, and 145/72 for blood pressure. She's 94% on room air. She's 163 centimeters tall. She weighs 58 kilos, which gives her a BMI of 23. So what is the pathophysiology of atrial fibrillation? It is the most common sustained cardiac arrhythmia seen in practice. The adverse outcomes that occur with Afib are related to the reduction in cardiac output that occurs and also the risk for atrial thrombus formation, which can lead to thromboembolic events and an increased risk for mortality. Patients with Afib are also at an increased risk for heart failure and hospitalization. Afib is classified as paroxysmal, persistent, long-standing, persistent, and permanent. Paroxysmal Afib terminates spontaneously or with intervention within 7 days of onset. Persistent Afib fails to self-terminate within 7 days and is often requires medication or electrical cardioversion to restore regular rhythm. Long-standing persistent Afib is Afib that has lasted for more than 12 months. And permanent Afib is a term used for those with persistent Afib who've made a decision with their healthcare provider to no longer pursue rhythm control strategies. In this case study, Rita has permanent atrial fibrillation. Hypertension and coronary heart disease are the most common chronic conditions in patients with Afib in developed countries. Some other chronic conditions that can lead to Afib in an individual are any valve issues that can lead to a significant stenosis or regurgitation. Heart failure. So heart failure and Afib go hand in hand, and each one can predispose the patient to the other. Hypertrophic cardiomyopathy is another risk factor or chronic condition that can lead to Afib. Congenital heart disease. So a common congenital heart defect is atrial septal defect, which can lead to Afib. Venous thromboembolic disease, so examples of this would be a DVT or a PE. Cardiopulmonary diseases, those are things like COPD, peripartum cardiomyopathy, lupus, myocarditis, pericarditis. And there is some evidence that says that obstructive sleep apnea also puts a patient at risk for Afib. Obesity is a chronic condition, so patients with a BMI of greater than 30 are more likely than those with a BMI of less than 25 to develop AFib. And metabolic syndrome is also a chronic condition. Metabolic syndrome is a term used for patients who have hypertension, diabetes, obesity, and dyslipidemia. And also chronic kidney disease is also a chronic condition that puts a patient at risk for AFib. So those are some chronic conditions that put a patient at risk. There are also non-chronic or secondary risk factors. Some of these would be surgery, specifically cardiac surgery, so things like bypass surgery or cardiac transplant, hyperthyroidism, infection, or an MI. These conditions can cause a change in the anatomy and electrical conduction of the atria, can lead to atrial enlargement, elevation in atrial pressure, or infiltration or inflammation of the atria. Spontaneous cardioversion to a normal rhythm within 24 hours is common because the atria are still healthy, but if the AFib lasts greater than 24 hours, the likelihood for conversion begins to decrease. After 1 week, conversion is rare, and that is related to the remodeling of the atria that takes place. So treatment options for atrial fibrillation are based on the course, the onset, and the persistence. There are some non-surgical procedures that patients can have done. Those are things like an electrical cardioversion. Oftentimes, patients will have a transesophageal echocardiogram done first to assess for clots in the atria, and often anticoagulation is recommended prior to the cardioversion. An ablation is another non-surgical procedure that can be done for atrial fibrillation. That's often used when long-term medication or electrical cardioversion is either not preferred or not effective. Some surgical procedures that can be done are a pacemaker or an open heart maze procedure. Oftentimes what you will see, however, are medications in these two groups, so anticoagulants or rate or rhythm control medications. The goal of anticoagulants are to prevent a stroke. They are recommended for most patients with AFib, but the benefit and risk have to be taken into consideration when deciding whether or not to put a patient on an anticoagulant, because they do have the risk of bleeding. One way to assess a patient's risk for stroke is the CHADS-2 risk stratification score, and this is to estimate stroke risk for non-valvular AFib. So this is a score. There's a calculator online you can find. It's based on 3 different categories: the sex of the patient, the age of the patient, and the patient's comorbidities. So female patients get a point, while male patients do not get any points in that category. Patients 64 years of age and less do not get any points. 65 to 74 years, you get 1 point, and if you're 75 years of age or older, you get 2 points. As far as comorbidities go, CHF gets you a point, hypertension gets you a point, diabetes gets you a point, history of stroke, TIA, or thromboembolic event gets you 2 points, and a history of an MI, peripheral arterial disease, or aortic atherosclerosis, those get you a point as well. The scale or the calculator is 0 to 9 points. Those with a moderate to high risk, so those would be patients who have a score of 2 or more. Warfarin has shown a significant reduction in the risk of stroke at an acceptable risk of bleeding compared to placebo. Patients are considered very low risk if they get a score of 0 and low risk if they get a score of 1. Those 2 groups of patients are not well studied, and each patient with their provider must discuss their individual risks versus the benefits of being on anticoagulation and make a decision based on that. Bleeding risk is more difficult to quantify with a calculator, and there are not many calculators out there that are accurate because there are different types of bleeds and different severity of bleeds. The most severe bleed would be an intracranial hemorrhage. Any bleed can result in death, but most usually do not. Up to date believes that most patients care more about an intracranial hemorrhage and less about bleeds such as a nosebleed or a GI bleed. With that in mind, the risk of an intracranial hemorrhage is higher for patients with certain risk factors. So those are things such as thrombocytopenia, or a known coagulation defect, active bleeding, or a recent surgery with concern for ongoing bleeding, a prior severe bleed while on anticoagulants, a suspected aortic dissection, malignant hypertension, or the use of antiplatelets while on anticoagulants. Some common anticoagulants that you've heard of are Warfarin, which are also known as Coumadin. Some non-vitamin K antagonist oral anticoagulants you may see them abbreviated NOACs. Those are medications such as Pradaxa, Xarelto, Eliquis, and Savaysa. It's important to note that Pradaxa is the only one of those four that has a reversal agent, but it is listed on the Beers list of medications to use cautiously in the elderly. And there's also antiplatelet regimens, but those are used for anticoagulation in Afib less frequently. UpToDate came up with this algorithm when a provider is deciding whether to place a patient on anticoagulation. It's based around 3 questions, such as should the patient be anticoagulated? If the answer is yes, which anticoagulant should be used and how should it be initiated? So the algorithm at the top uses the CHADS-2 score to decide whether anticoagulation is suggested. So as we just talked about, a score of 2 or more indicates that the patient should be on anticoagulation. A score of 1, the benefit to risk ratio varies, so it's important to assess the patient-specific risk factors and bleeding risk, but generally anticoagulation for a patient who scores a 1 on the CHADS-2 score generally are recommended to be on anticoagulants. A score of 0, the benefit to risk ratio does not favor anticoagulation, but a patient may choose to be on anticoagulants because they feel that it's important to them. Going down through the algorithm, there's a box that says, is the TTR greater than 65%? That is talking about the time in the therapeutic range. So the time that the patient has a therapeutic INR is at more than 65% of the time. If the answer is yes, it's recommended that the patient continues Warfarin. If not, it may be an indicator that they could try an NOAC. There are some times to avoid an NOAC, and those are in patients who have a creatinine clearance of less than 30, patients who are on medications that may have a significant reaction with the NOAC, so those are anti-epileptics and HIV medications are common ones that interact with NOACs. Patients who are at risk for NOAC accumulation, so those are patients who may have a fine creatinine clearance but a low body weight. There are also a few groups of patients that are not well studied with NOACs, so it may be wise to avoid NOACs in them. And those groups of patients are the morbidly obese, patients who weigh less than 60 kilos, or patients who are 80 years of age and older. If the NOAC is unavailable or there's cost concerns for the patient, it's not wise to prescribe them. Or if there's concern about the lack of reversal agent, so as I said, Pradaxa is the only medication that has a reversal agent. Or if the patient is pregnant or breastfeeding, it's important to avoid NOACs at that time as well. And again, NOACs are Pradaxa, Xarelto, Eliquis, and Savaysa. So going back to treatment options, rate or rhythm control is the other group of medications that you'll see. Both are acceptable methods with comparable rates of mortality and stroke. According to UpToDate, preference is for rate control in asymptomatic patients and rhythm control in symptomatic patients. They also suggest that in those over age 80, rhythm control is less preferable because the elderly are more sensitive to some of the antiarrhythmic medications, and also Afib is often permanent. Rate controlling medications are things like beta blockers, calcium channel blockers, and digoxin. Rhythm controlling medications include sodium channel blockers and potassium channel blockers. So what is our recommendation for Rita? We know that she's an 80-year-old with permanent Afib. We know that she's on an appropriate rate controlling medication, the metoprolol, 25 milligrams twice a day, and it's appropriate for Rita to be on a rate controlling medication as her Afib is permanent and she's over 80 years of age versus a rhythm controlling medication. When we do her CHADS-2 score, we get a risk stratification score of 5. She got 1 point for being female. She got 2 points for being over 75 years of age, 1 point for her history of MI, and 1 point for her hypertension. A risk score of 5 indicates that the benefit to risk ratio favors anticoagulation unless she's at a very high risk for bleeding. So some important predictors of major bleeding would be over anticoagulation with warfarin. That would be shown by an INR greater than 3, a prior stroke, and an increase in patient age. So Rita is slightly over anticoagulated at this time. Her INR at the office is 3.5. She has not had a prior stroke, but she is at an increased age. When we are thinking about her risk for an intracranial hemorrhage, she does not have some of the other risk factors that we talked about earlier. So those were things such as thrombocytopenia, active bleeding, aortic dissection, malignant hypertension, or the combined use of an antiplatelet and an anticoagulant. But she has had a severe bleed in the past, the GI bleed. So it's important to keep all of those things in mind, and we can see that Rita is at a risk of bleeding. We also know that she has a persistent thromboembolic risk. She's got atrial fibrillation, so she is at risk for clot formation and a thromboembolic event. And that risk is not something that's going to go away. It is a persistent risk for Rita. We could go on to the algorithm that UpToDate gave us, so we'll go through that in a minute on the next slide. We also want to consider her environmental safety risk. So we know that she has fallen frequently at home and has a 2-story home. That puts her at greater risk for falls and trauma, which could lead to bleeds. After all of these considerations, we want to discuss with Rita the risk versus the benefit of staying on warfarin and allow her to make an informed decision. After doing so, we learn that Rita values avoiding a thromboembolic event and wishes to stay on anticoagulation. But then we're going to go through this algorithm to see if we can switch the medication that Rita is on, the anticoagulant that Rita is on. So we're going to start at the top with her CHADS-2 score. We know she got a score of 5, which suggests that she should be on anticoagulation. The next box asks, has she had a ischemic stroke within the last 30 days? And she has not. So then is she already on an anticoagulant? Yes, Rita is on warfarin. Is her TTR greater than 65%? So we talked about how over the last 6 months there's been difficulty with getting her INR in a therapeutic range, and she's had multiple INR draws to dose her warfarin because of that. Rita has been on Coumadin since the age of 65, so overall her TTR time has been greater than 65% of the time. So that being said, following this algorithm, it suggests that we should continue warfarin. If we wanted to consider an NOAC for our patient, we would think about the groups of patients or the risk factors that make us want to avoid them. One of them was age equal to or greater than 80 years, which Rita is. So we would not want to recommend an NOAC for Rita because there's not enough studies to suggest that it's a safe medication for her. There are some advantages to NOACs, such as the convenience. There's no need to dose them based on an INR. There's a high relative but small absolute risk reduction in the risk of intracranial hemorrhage in the NOACs versus warfarin. There's less dietary interactions and less drug interactions. So for certain patients, they are worth looking into. Looking at warfarin specifically, its mechanism of action is that it depletes functional vitamin K reserves and reduces synthesis of active clotting factors. The onset of action when taken orally is 24 to 72 hours. Full therapeutic effect is in 5 to 7 days, but the INR can increase in 36 to 72 hours. The targeted INR range for non-valvular Afib is 2 to 3 with a target INR of 2.5. Warfarin is contraindicated in patients who have a hypersensitivity to the medication or any component of the medication, patients who have hemorrhagic tendencies such as active GI ulceration, GI bleeding, respiratory tract or GU tract bleeding, cerebral aneurysm, central nervous system hemorrhage, dissecting AAA spinal puncture. They also are contraindicated in recent or potential surgery of the eye or central nervous system, a major regional lumbar block anesthesia or traumatic surgery, blood dyscrasias, malignant hypertension, pericarditis or pericardial effusion, endocarditis, in patients who have a high potential for noncompliance, in preeclampsia or eclampsia or threatened abortion or in pregnancy. They are contraindicated in pregnancy unless a woman has a mechanical heart valve and is at a high risk for a thromboembolism. The biggest adverse reaction, 1 to 10% of patients may have major bleeding. The risk, of course, increases the higher the INR is. There is some genetic factors that could influence a patient's sensitivity to warfarin. However, genotyping is not recommended routinely before dosing a patient. Lower starting doses may be required for patients with liver impairment, poor nutrition, CHF, elderly, high risk of bleeding, or patients who are debilitated. Foods high in vitamin K can inhibit the anticoagulant effect. So those are foods such as leafy greens. We oftentimes think of those, but also green tea, chewing tobacco, and many different kinds of vegetable oils have a lot of vitamin K in them. So patient education and plan. So we're going to instruct the patient to report any signs or symptoms of bleeding, to report any accidents or falls, to report any new or discontinued medications or herbal medications, to report any drastic changes in diet or smoking behavior. We're going to have the patient get their INR checked when instructed by the provider. We're going to educate the patient on how alcohol should be avoided while taking warfarin, and we're going to instruct the patient to take the warfarin at the same time each day, and also to avoid drastic changes in diet, but if changes are done, to notify the provider. Our plan to implement is to get a home health nurse involved for medication management and a home safety evaluation. We're also going to counsel the patient to have 1 alcoholic beverage on Monday nights instead of 2 to try to cut down on her alcohol consumption while on the warfarin. We're going to assess the patient's understanding of how to make changes in her warfarin dose if instructed to do so by her provider based on her INR. We're going to assess the patient's ability to pay for medication. Her warfarin will cost $5 to $15 for 35 milligram pills. And we're also going to have a follow-up with the patient in 3 to 4 weeks to assess the effectiveness of the treatment plan, assess Rita's comfort with the plan, and to reassess her lab work to make sure that they're all within the therapeutic range that we want them to be. So that concludes my case study. Here are my references, and I hope you enjoyed it. Thank you.